Hi, my name's Abby. I'm the Clinical Nurse Advisor at Armstrong Medical, and for this short video we'll be taking a closer look at the challenges in the post-operative care, specifically post-operative hypoxemia. Hypoxemia is defined as inadequate tissue oxygenation due to either inadequate blood flow or arterial oxygen content. This condition can be attributed to two primary factors. So first, it can be caused by disruptions in gas exchange induced by anaesthesia, which may persist for hours or days in the post-operative phase. Second, an irregularity in breathing control can manifest as episodes of obstructive apnea rather than a reduction in respiratory rate, and this can extend for several days or nights following the operation. Post-operative hypoxemia is one of the most common complications after surgery, often due to atelectasis or lung collapse, VQ mismatch, or pulmonary edema, and there are studies that report an increase in mortality as high as 27%. Patients with post-operative hypoxemia can face longer hospital stays and extended rehabilitation. Understanding the causes of post-operative hypoxemia is vital for its prevention and management. Several contributing factors can be categorised as follows. So anaesthetic agents can temporarily depress the respiratory function, alongside opioids for pain management, which can suppress your respiratory drive and lead to hypoventilation. And also the position of the patient during surgery can impact oxygenation, as some positions can compress lung tissue, leading to reduced ventilation and impaired oxygen exchange. The duration of surgery can also increase the risk of hypoxemia. Surgeries involving the chest or abdomen can significantly impact breathing mechanics due to the proximity to the diaphragm. Patients undergoing these procedures are more susceptible to post-operative hypoxemia. Patients with pre-existing conditions such as chronic obstructive pulmonary disease, COPD, or obstructive sleep apnea, those with cardiovascular disease, or patients that are morbidly obese are all at higher risk of post-operative hypoxemia. The elderly are also more susceptible to this due to a decline in lung function with age. So various interfaces can be used to administer oxygen post-operatively, including a simple face mask, low-flow nasal cannula, or high-flow oxygen therapy. So how can high flow help post-operatively? So the delivery of high flow clears out that upper airway, creating a humidified fresh gas reservoir by washing out the nasopharyngeal area, which reduces that anatomical dead space. And that enhanced alveolar ventilation that this reduction of dead space provides contributes to better oxygenation through increasing the volume of oxygen available in the alveoli. That nasopharyngeal dead space washout clears those waste gases from the upper airway, which prevents CO2 rebreathing. And the high flow that we're able to administer on the high flow device allows clinicians to meet or exceed the patient's respiratory demand and provide a constant FiO2, and that in turn can help reduce the patient's work of breathing. There's also some evidence to show a varying degree of positive airway pressure. This is all dependent on flow rates, whether the patient's mouth is open or closed, and the size of the nasal cannula in the nares. The alveolar recruitment post-operatively may also benefit patients at risk of post-op atelectasis. The addition of the heated and humidified gases can also help with warming strategies to maintain normothermia, so normal body temperature. In theatre, hypothermia is a common issue. It's a result from a combination of anaesthetic impaired thermoregulation and that exposure to the cold operating environment. Having the heated and humidified gases post-operatively may assist with patient comfort and step down in recovery. During surgery, the airway can become dry due to a variety of factors, including the use of anaesthesia, the administration of dry cold gases through a breathing circuit, and the natural evaporation of moisture from the airway. The heated and humidified gases used during high flow therapy assist with your mucociliary clearance, and it can provide some relief from a dry throat following fasting or extubation. And it can also reduce the risk of post-op complications such as irritation and inflammation in the airways, which can lead to coughing, difficulty breathing, and other respiratory problems. High-flow oxygen therapy therefore has the potential to improve oxygenation for hypoxic patients, given the improvement in patient comfort, dyspnea, respiratory rate, and gas exchange. The alveolar recruitment in high flow may also benefit patients at risk of post-op atelectasis. Oxygen therapies such as high-flow oxygen therapy have gained prominence, showing improvement in oxygenation and reducing the risk of reintubation. These therapies are also recognised for its potential to enhance patient comfort. Ultimately, the choice of oxygen therapy in the post-operative period should be tailored to the patient's specific needs, considering your risk factors and individual characteristics. These advancements in oxygen therapy techniques signify a positive shift towards a better post-operative care, particularly for your high-risk patients, and enhancing patient outcomes and quality of care.
If you have any questions or comments, please feel free to leave them in the comments section below. Don't forget to check out our website for more information on high-flow oxygen therapy for perioperative care.